Hello and welcome, everyone. We are waiting for people to join us as they log in. We're very excited to have you here today as part of our follow-up ongoing conversation to support LEAs in responding to COVID-19. And in particular, this is a more focused follow-up to the webinar that we had last week. And what we decided to do was launch the guidance that just came out from the Safe Schools for All plan. We talked about a hub and the team that will be supporting all this great work. And we have been collecting questions from many of you. And so today we're going to have kind of a more informal Q&A session with our expert presenters. And so we're really appreciative of your time and we thank you for joining us. We know everyone is incredibly busy right now. We want to also bring to your attention, based on the feedback that we have received from our participants, we are very fortunate to be joined by Katie and Candy, our ASL interpreters. They should be pinned and visible on your screen. And if for some reason they are not, please submit. You can submit through our Q&A feature to let us know, and we will try to provide you with some assistance. We've also activated a live captioning feature as well to hopefully support, facilitate the conversation and understanding of the content that will be covered throughout the next hour. As usual, this is the webinar feature and you will be muted and you can use the Q&A function to submit questions. We will continue to collect questions. We've been collecting quite a few and we appreciate the feedback. And so we want to just remind everyone this is part of a series and we've had the opportunity to check in with all of you in November and December last week, and here we are again. And as I mentioned, this is the follow-up Q&A to that session, and we will have a continued conversation and discussion on the guidance. And we're very fortunate again today to be joined by a great team of presenters and experts. We have Dr. Naomi Bardock, our state lead from the Safe Schools for All team. And because she's brand new to the team, we didn't have as much time last week to say hello and get to know her a little bit better. But Dr. Bardock, if you could give us a little bit of your background, we'd love to hear more about you.
Yeah, no problem. I grew up in Berkeley, California. I went to school in New York City for 4 years and then I came back. I have two children. They're 11 and 13-year-old boys. One of whom really struggled in the spring. They're both doing better now for schooling. And I am a clinician. Usually my clinical job as a pediatrician is at San Francisco General Hospital. I work in San Francisco. I live in San Francisco at the county hospital. So take care of a group of students that part of my motivation for getting involved in this work was actually trying to really help out those students who I got pretty worried about in the beginning of the pandemic. So that's
great. Thank you.
and
Welcome.
I'll say I like to sing as the other personal, we'll give one of our personal tidbits.
That's the best part. That's great. Good to know. Thank you. And we also have Paula Viesquez, the Assistant Secretary of the California Health and Human Services. And Paula, I know you've been traveling remotely, virtually up and down the state, meeting with many groups, many LEAs talking about testing. But if you could also share maybe a little bit about who you are and your background.
Sure. Thanks so much, Michelle, for the opportunity. Glad to be part of the team. I think I have hit most, if not every corner of the state virtually, as you've noted. And so there's a significant chance that I've seen you or a member of your team in one of our webinars or office hours related to testing, and particular the activities at the Valencia branch lab. I think most people are probably familiar with wearing a couple of different hats during this particular season. During non-COVID times, I help coordinate the work on the human services side of our agency related to that effort, but throughout the course of this event have helped to navigate some of the efforts where they overlap between our public health partners and our education partners. And so you know, in that vein, have been in the last couple of weeks now, starting to transition into months, helping coordinate the work of the schools branch of the testing task force. And I'll go ahead and offer as well, because we were on a webinar earlier and I was kind of outed for my other hat that I wear, but
Yes.
I'm also a governing school board member in my local school district as well, offering a little bit of that overlap
Yes.
and perspective.
I was planning to bring that up as well, so I'm glad you did. That's great. That's great to know. Thank you. And then Brooks Allen, our Executive Director of the State Board of Education. Brooks, do you want to just say a quick hello and let us know who you are?
Sure. Hi, Michelle. My name is Brooks Allen. I serve as the Executive Director of our State Board of Education and advisor in the Governor's Office. I've been in this role since October 1st and have been really engaged with the team, Dr. Bardock, Paula, and others across the administration in trying to help out roll these pieces. Have a personal link there as well as my children since last March. A 5th grader and a 7th grader have been in distance learning since that time, and obviously have close touches around issues around COVID-19. So feel this one very personally, and it's a pleasure to be part of the team, and look forward to the conversation.
Thank you. And again, just a reminder for everyone, we are in webinar mode. The Q&A feature is active, and so you can submit questions or even comments. We will be posting the slides, and you will have access to those along with the recorded version of the webinar and any additional resources that we may identify throughout. And so today, as I mentioned, we're going to launch into Q&A. This is the follow-up to last week. And what we're going to do is we're just going to go through various topics that are covered in the guidance. We've actually ordered the topics in terms of the number of questions that we received. We received hundreds of questions, and we did our best to synthesize and group and really hit the areas right now that we think are most urgent for people to understand. And then Dr. Bardock will also remind us around the options to continue to submit requests for help, upcoming trainings, upcoming FAQs. And so we're really excited to hear about that. But we're going to go through kind of the guidance and criteria. We do have a short video in that section, and then we're going to shift into testing. We'll talk a little bit about plans, cohorts and stable groups, some distancing questions. We've got funding questions. We've also had questions around the reporting requirements that are coming up. We do have the section around vaccinations. We might be able to speak to those a little bit, but that is definitely an evolving topic as we speak. And so with that, Dr. Bardock, I'm going to turn it over to you and kind of set the context of what to expect around the support, and in particular, the Safe Schools for All team.
Yeah, great. Happy to talk a little bit more about this. Michelle and I, before this webinar, we're talking about all the questions that have come in since last week. I think it was something like 200 questions. And so we know there's going to be ongoing questions, and that we're hoping to get to a lot of them today, but we won't get to all of them. So there's a couple things that are coming up that I think might be helpful, either that already exist or that are coming up. One is the upcoming facts. We're going to have a frequently asked questions on the school guidance. So we're working on that based on actually the questions that are coming in here, and also questions that we're getting from other places. There's also the technical assistance request form. So whether you have a more general question or a very specific question, there's that technical assistance is at the Schools Hub website, which we can put in the chat, but it's schools.covid19.ca.gov. Oh, there you go. Look at that. So nice. Thank you. Right at the very top, there's a button that says technical assistance for school administrators. And so that would be another way to get questions answered. There's also UCLA and UCSF Virtual Training Academy. They're putting together a bunch of resources. And actually, they asked us for the list of questions from this webinar that could populate their resources as well. So we're trying to, of course, the feedback we get is extremely helpful and is going into ongoing materials that people are making, and then other upcoming webinars from CCEE and other places. So just to highlight that there's other places to get questions answered, since we only have an hour today and we couldn't get to everything. So
great, thank you. All right, so we're going to jump into the guidance and criteria section. So one of the first questions we received is, for schools that are already open, when will the new guidance need to be implemented by?
Do you want to you want to tell us who should answer? I'll jump in. You will.
Anyone could jump in, and we can add. We can add on.
Perfect. Yeah, exactly. So the timeline for those who are already open, the timeline for posting your COVID safety plan, which includes those two pieces, which we'll probably get to in a couple minutes, but one of which is the Cal OSHA prevention program plan, which is already, usually people should already have written it because the emergency regulations came out in the end of November, beginning of December. So there's that piece. And then there's the checklist. And the checklist might be what people are thinking about, which is that's where you have to say what your physical distancing sort of what you're doing in terms of physical distancing, what your stable groups look like, what your testing cadence looks like. So anybody who needed to like adjust their physical distancing, it's that COVID safety plan is supposed to be posted by February 1. So ideally your people are already working now if you do need to make any adjustments to move in that direction, but that would be what I would say is sort of the stated deadline, at least in the materials.
Yep. And we do have some questions around the plans as well. But it seems like, you know, with the launch of the Safe Schools for All plan, the directives included, the hub, all of the content, you know, pretty much most of this is in effect, right, immediately. We do have some unique or distinct deadlines, like you mentioned, February 1, we've got January 25th for the reporting. But for example, the Cal OSHA ETS, emergency temporary standards. We had the webinar on that December 10th. And so those were effective immediately. We did get some questions around that as well. And so I'll go ahead and move on to the next question. And then Paula, I think you can also jump in as well. Can schools that reopened with a waiver use the previously approved school reopening plan for the CSP?
Okay, great.
No, go ahead, Paul.
No, I was actually going to volunteer Brooks, but if you wanted to get started, you should get us started.
We could start with Brooks too.
I'm happy to answer. The quick answer is that the COVID-19 safety plan is composed of two elements, and you wouldn't have necessarily had, depending on the timing of that waiver. The first one was just to fill out that the Cal OSHA piece of the plan, as well as to complete the checklist, which is new. So you would need to have both those pieces. That said, many pieces of what you would have put together for that waiver would be pieces that would be information that you'd be inputting into that Cal OSHA plan, as well as checking off as part of the CDPH checklist. And so I think you'll find that many of the components overlap, and the idea was to make it a fairly streamlined process aligned with those two. Dr. Bardock, Paul, I don't know if you have anything else you want to add, but that's where I'd start.
Yeah, I think that I've heard from a couple people saying, you know, why do we have to do both? And I think that just to clarify, the idea was that we do want there to be some consistency and clarity and transparency. That's kind of the goal of doing it. But we also wanted to make sure it wasn't a big burden. So we're leveraging the things that we hope people are already doing, which is the Cal OSHA piece, that's already something that would be in the works. And then also there's the checklist is a pretty light touch checklist because it's mostly just checking off the boxes. So you need to have done all the work behind it is substantial, but the paperwork should be limited.
And a little bit to add, supporting the statement around kind of minimizing the burden as much as possible. We're really not looking to continue to move the goalposts on folks. And so if you're looking at the checklist and say, hey, this looks a little bit familiar, it should. Most of it is in part from the elementary school waiver with a few adaptions where necessary in order to accommodate kind of what we know about the virus and how it transmits and some changing pieces. But again, if it looks familiar, you're not looking at the wrong document. It's supposed to.
Okay, great. Okay, are school districts prohibited from reopening if they are in a county with case rates above 25 per 100,000, regardless of whether they were issued a waiver? And we did get quite a few questions around the case rates, so.
So just to clarify, if somebody was issued a waiver but they hadn't yet reopened, then they're not able to reopen if their county is above 25 per 100,000.
And I know you talked about the science behind that. We did get some questions related to that. Is there anything that you can kind of clarify or add to that criteria that was identified?
I think that there's some the questions that I've also been hearing is why can people stay open if it's above 25, but you can't reopen if you haven't already if you haven't already reopened. And I think it is helpful to speak to that particular piece, because I know it feels a little confusing. And the goal is a safety goal, right? And so we know that we have very, very high rates in some communities, and that starting a reopening process is, reopening a school with all of the layers of mitigation is it's operationally complicated. And so being able to say, oh, it's fine in this very, very high case rate situation to open, if you haven't already had practice doing it, is probably just not a great idea. It doesn't mean that people shouldn't be planning, because the hope is that we're bending the curve, and the goal of this effort is actually to support people in their planning so that when we get below 25, that people are able to do it. But it's just the layers of mitigation are so important. And we know that if there are high community rates, that there's just more people who are going to be on campus who might have an infection. And so we want to make sure that people have all those pieces in place. And if you've already been reopened, that we kind of know that that's already there.
That's really helpful. Thank you. You actually kind of just answered this question. I think we were looking ahead also. We've got these questions that are very similar, a lot of overlap. So you actually just answered this question here in terms of the science behind. So for the second question, if schools are not transmission vectors and generally have lower cases than the surrounding community, why aren't schools allowed to reopen if they follow guidelines to close, given that case rates exceed the thresholds in a classroom, school, or campus?
I think I don't totally understand the very last part about that. Given that case rates exceed the thresholds in a classroom, school, or campus, I would say so. Yeah, great. I think that the science behind that about schools not being major transmission vectors in lower cases is what gives us confidence to do the reopening, or to really encourage people to reopen. And it's what the CDC said last week, and what the governor continues to say, which is schools should be the last to close and the first to open. So that's based on that data. So I think the data suggests that there's a desire for people, understandably, on the teacher side, on the family side, to actually see that data. So as we get more data, as schools open, if we can see that is really happening, then it will inform us. Right now, that's why there's a push right now also for transparency, so that we want to, that's one of those pillars, is that the transparency around case rates in our own schools. We need to see that and understand it in order to give us the confidence to be able to keep moving forward.
Okay. Great, thank you. And again, this third question is related to the case rates, and I think we've touched on the response. So just to give you the context, we did receive most of the questions around just the guidance and criteria, and in particular, the case rate information and the evolving science behind it. And we've mentioned that with every webinar, we've been providing that context, and it seems like every time you have a new study that you're sharing. So it's great to hear that we're going to have more local data, state-driven data, to help us make more decisions. So I believe we're going to be transitioning next to the video. So I'm going to go ahead and click through it. It opens up automatically. And this is, again, just to provide a little bit of reminder of why we're doing what we're doing.
So we're talking about how to do an anterior nasal swab today, and help instruct students to do that on their own, to self-swab. And to do that, for my protection and for protective equipment, I need gloves, a face shield or face goggles, and just a regular mask. You're going to be 6 feet apart from everybody, and the teacher is going to help you wash your hands. You're going to wash your hands before you do the test. So there we go. Washing our hands with some hand sanitizer. Okay, so what you're going to want to do is we're going to hand you the swab, okay, and you're going to want to take the stick. You don't want to touch anything. You don't want to touch the soft part of the swab, which is kind of like a cotton swab, okay? So you're going to hold it, and you're going to wait for instructions. And then, when we say so, and we're far enough away from you, because we want to be far away when we take down our mask, we're going to have you take down your mask. And you're going to take the swab and you're going to put it in your nose like you're picking your nose. And the whole point of this is to get some snot on the swab. And you really want to both rotate the swab and twist it, but you also want to take the swab and go around in your nose, kind of like you're picking your nose, and really get all the sides of your nose area. We're going to do that for a count of 10 to 15 seconds. So let's count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay? And we're going to take it out. We're going to switch it to the other side. Okay? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay? And then you're going to want to hold your swab again, not touching the top swab. You're going to want to wait patiently for one of the adults to come and take it so that they can run the test.
Great. So this sets us up for the next topic, which Paula is very familiar with, but it's also just the reminder of what it looks like, you know, when we're actually testing, and the supervised self-administered test has been a topic many people have been discussing. And so Paula, I'm going to, in a sense, turn it over to you to give maybe a little bit of context around where we are with testing, and then maybe we can go into some questions. How does that sound?
Sounds great. Thanks, Michelle. So I'll go ahead and jump in and offer. First, I'll let everybody on this webinar know that there's a number of opportunities to engage more, engage further and at a more deeper level at the Valencia Branch Lab for anybody that has outstanding questions. But I want to provide just some general updates on kind of where we're at, and then definitely get into questions. And so, we, as soon as the lab was stood up, schools and our school communities have been a priority for engagement in the Valencia Branch Lab. And accordingly, we began to engage with a couple of early adopters that graciously worked with us to really iron out some of the wrinkles and make it as user-friendly as a process as possible. And then we started engagement with CCEEE and our County Office of Education partners to start outreach. And where we currently stand is we've got roughly, I think we're at about 130 school-based sites that are testing within the Valencia Branch Lab. And we've engaged with 35 of our County Office of Education partners. And that engagement continues in earnest. And so if we already haven't had a discussion and you or your team are interested in learning more, definitely encourage folks to reach out. We've got our testing task force email, and perhaps if there's a follow-up, we can also provide it, but it is testing.taskforce@state.ca.gov. So that's one way to engage, but also there's a number of resources both on the Schools Hub and on our testing task force website. It's pretty easy to find me. So look forward to talking to anybody who wants to talk about the Valencia Branch Lab. And also one thing I just want to take an opportunity to discuss is it does look a little bit different from what we originally launched really in the fall. And that's to say that we've been working overtime to try and solve for some of the bigger challenges that have come up. So a couple of the pieces that I want to touch on is what we're calling CCN, our COVID courier network. And that really is our state-based solution for probably one of the biggest problems that we heard from our school-based partners, which was that the responsibility of getting the specimen back to the lab, Valencia Branch Lab, was a pretty significant hurdle. There were a number of contributing factors to this. One, shipping just takes time and it takes resources. Additionally, we were in the height of the holiday season, et cetera. So we have since stood up our COVID courier network, which is a series of drop-off locations. And I'm proud to say we're on time and on schedule. We currently have 20 set up throughout the state, with more coming online towards the end of the month. And our goal really is to be able to offer to all of our community sites a drop-box location and appropriate access to those drop-box within a 2-hour drive of everybody, if not closer. Additionally, we're always standing up new resources. And I think one of the things I want to say is the advantage of going to Valencia Branch Lab is that it is an effort and a partnership led by the state, as opposed to a lot of our company-based partners. we really are endeavoring to ultimately bring down the cost and meet your needs. It's just a different type of relationship. And we've got a number of partners that we brought to the table to help meet your needs. And all that's to say is, additionally, we're not looking to disrupt anything that you've got going that's working well right now. So there's quite a bit of flexibility built in, so that if you have a current existing contract with Curative or another vendor that is working for you, fantastic. And if you're looking instead just to supplement an increase in volume or solve for a couple of pieces in places where you haven't been able to, we stand ready to do that as well. I could go on for a while, but I won't. We'll go ahead and jump into questions, but I appreciate you letting me have an opportunity to provide some of those general updates.
No, that's great. I feel like every time I hear you present, you have something new to share. So it's always helpful to get those updates. So the first question, we were recently approved by Valencia Branch Lab to begin a testing program whereby the test kits are free to the school district and the kit processing will be billed to insurance carriers by the state. Can you provide us with assurance that the insurance carriers will not bill us back for the test processing?
Thank you. And yes, I can. So the way it has been set up, which is, in fitting with the question, is that the state has paid upfront for the test kits. And I'll also say that the test kits are a PCR test for $55 at the moment, but we're working really hard to bring that down. But that cost is provided upfront by the state. Our default method of recouping some of that cost is our insurance billing option, which most of our existing partners are utilizing, whereby we, utilizing a third-party billing vendor that is built into our services at no additional cost to you and your school district partners, they then use the information already kind of built into HIPAA authorizations and safely and securely obtained to then bill insurance as appropriate and as needed. Built into that contract and that effort with Sutherland is a no balance billing provision, which is to say in instances where folks might be underinsured or there is no insurance found, the state recoups the cost. The state picks up the cost rather.
Wow. Okay, great. Can you clarify if the testing guidance will be a recommendation or a requirement?
Sure, and I'm sure the person who asked this question, or the many individuals that asked this question, as Michelle noted, some of these are recurring questions that come up frequently, but in the table, in the guidance, you'll see that it is very deliberately titled, a cadence with which the state will offer support. So that's to say that is the level at which if you came to Valencia Branch Lab, we stand ready to help and support. However, in terms of concrete public health recommendations, a lot of those, that is largely and very dependent on a number of things, both your local health conditions and the level to which you're engaged in other non-pharmaceutical interventions and risk mitigation techniques. So I'll pause there to see if Dr. Bardock or anybody else has anything to add, but I'll just clarify that the table in the guidance is what the state is willing to support through the Valencia Branch Lab.
And I think sometimes this question comes up in terms of the funding. Brooks, do you want to mention? And I think it's maybe helpful. Sometimes people conflate the guidance and the funding piece. And so I think it's helpful to help people separate those two out. So Brooks will give the answer on the funding question also.
Yeah, and with respect to funding, it's important to clarify up front that this is a proposal that the governor has made, is now in front of the legislature. So I've seen a number of the questions. It assumes that we have a grant program that is in place and that folks can be applying for. We have a proposed grant program. So even the details that we share today, depending where it lands, may shift a little bit. So I just want to be really clear about that up front. But it is, as both Paul and Dr. Bardock noted, it is a source of confusion because the proposed grant program would require, as a condition of receiving those grants, that those local educational agencies have a plan for getting to those testing cadences that are supported by the state. And so that has been a source of some confusion where folks have thought that that would mean it's a requirement for everyone. It is not, as was just highlighted, but it would be if the grant program as proposed were enacted for those who participate in receiving those funds.
Yeah, we've received quite a few questions related to that, so that helps. What happens if parents and staff refuse the testing cadence as outlined?
Yeah, and I think this is also a good opportunity to kind of clarify. I think the literature and the resources built out assume kind of a built-in opportunity, and for folks, there's an assumption that they're offering the testing cadence and that an LEA stands ready and prepared to offer that testing cadence. And so I will just offer that clarification, that distinction between offering, and you'll see, nowhere built in any of the information or resources as a requirement on the participant side to do it. And so that's to say, other than encouraging folks to kind of reach out to our school TA team or other items, and we're happy to kind of help on any kind of public health side on the benefits of testing. But the Valencia branch lab side in particular, there's nothing built in that's going to say like, oh, you didn't make sure that every single one of your children on campus is state tested, so we're kicking you out of the program. That's not the case. There is an expectation that kind of the offering and an obligation to offer it is met.
Great.
And maybe I'll add one other thing, which is that I think sometimes the underlying part about this question is an understandable one, which is that there's some worry that families won't want to participate, kids won't want to participate, that'll be hard, the feasibility issues are real, and even people who have already been doing the school testing with their staff, I think are, they're just worried about the feasibility issues. So I just want to offer a couple different things that I have found helpful as I listen to this testing task force does this amazing work. There's a couple really useful things. One is, so the student piece of it, that video I think actually illustrates that the supervised self-collection for kids can actually be a very viable way of doing it. The kids, when they hold the swab, they're actually very comfortable. Those kids were as young as kindergarten. There's even a TK kid in that video. So I think that sense of feasibility, I think, is important, because the other image people sometimes see is like, there's a person with a lot of protective gear, they're leaning over a kid, the kid is their nose back, and that feels like, oh my God, I have to do that for every kid in my school. That feels harder. And so I think that piece of the supervised self-collection, I think, is probably helpful. Somebody asked in the question and answer, can we do a group of kids at a time? Absolutely. Like what you saw in that video, you could do a group of kids at once. It doesn't have to be each kid observed one at a time. So that's one piece of the feasibility piece. The other one is that the testing task force in the Valencia branch lab is working on very close to having a system validated and okayed, where teachers can actually do their own self-collection without being observed. They could do it at home, they could do it on school campus, and that all of a sudden also relieves a lot of the logistical lift. So I think that that's just another thing for people to be thinking about. And the last thing to say is that in terms of parent comfort of kids doing this and kids' comfort, I did a study over the summertime actually trying to look at like, how can we make this, sort of be a comfortable thing for kids? And the type of testing that is being, shown here and that the Valencia branch lab recommends and the science recommends is what's called anterior nares, front of the nose only. It's different from the nasopharyngeal, which goes all the way back. So when there are families who we recruited in our study in the summer camp setting, when they first heard COVID testing, they're like, no, I'm not doing that. But as soon as they heard, oh, you can just do the front of the nose, then the parents were comfortable doing it themselves and they were comfortable with their kids doing it. So I think it's just helpful. There's like these little nuances and little details, but they can really change the tenor of the conversation and people's comfort and sort of logistical and operational capacities.
Great.
And if I could add, Dr. Bardock, thank you so much for those additions. But I think as a whole, if I could just umbrella package those, as another opportunity within the Valencia branch lab is that we're constantly striving to keep up with the latest technology and techniques to really make it as easy as possible. Ease of use is a top priority because we know how significant and important that is to really making it a useful tool at school sites.
Great, thank you. Will you provide templates and flowcharts for contact tracing? This would be very helpful, especially for small districts.
Can I actually jump in on this?
Oh yeah, go ahead.
You might already know that, but I saw this question yesterday, and I actually asked for somebody to do this. So our contact tracing team is aware of this, and TBD. But yes, we will do it. If they don't, they might already exist, but if they don't, we're working on it. But Paula, feel free to add.
There's absolutely nothing to add. The answer is yes. Heard, on its way. Thank you, Dr. Barda.
Yeah. First she's doing publications, now she's putting together flowcharts. This is great. Thank you. Okay, so we did actually address some of the content related to the plans, but I'll just go back through and read these questions again if we want to add anything. So is the CSP, which must be posted by February 1st, any different than the school-wide reopening plan that was required to be posted prior to us opening in August 2020? And so Brooks, I know you did provide clarifying distinction. It's really helpful to hear this again, that they are not two necessarily distinct plans. I think we've even seen out in the media more recently that it's like a brand new plan. It's separate than what we were submitting to plan. So again, anything that you can add to clarify the process, it would be great. If you want to add anything else.
Really, just to emphasize that point, Michelle, which is that for folks that have done their Cal OSHA piece, and that was mentioned earlier, that those emergency temporary standards came online on November 30th, and many were putting those together. And I know we're working on actually using the Cal OSHA template that Cal OSHA already provides and making it available on the hub as well. So you'll be able to see that piece of it. And then as Paula highlighted, the second piece of that is going through that CDPH checklist, which really covers, as I said, many of the areas that you would have covered with your initial plan, and just certifying that you've covered all those pieces and provide that information. That's it. Those two pieces, they get posted. That's it. That's the plan. They do cover important topics, but they're all topics that if you had a reopening plan were put together, you will have covered those subjects.
Yeah, okay. What does CSP stand for in this context? And I believe if more than 7 business days have passed since the submission without the input from the local health officer, the CSP shall be deemed approved.
So I can try to jump in on this one. This is still your COVID-19 safety plan. So the CSP still stands for the same thing. In this context, and I believe the questioner has lifted this sentence from a section that discusses the fact that if you are in a county or a local health jurisdiction that has a case rate that is under 25, but you're in the purple tier, you would be eligible to submit a plan to bring back your elementary school students. And so if you would submit this plan to your local health officer, and they'd have 7 business days for that review. After that 7 business day review, if nothing was found to be unsafe during that time period, that plan would be deemed approved, and therefore you could move forward with bringing those schools back for in-person instruction.
Okay, great. And then in terms of the actual approval by February 1st, does the local health officer have to approve the document, or do LEAs have to submit the document to the local health officer by February 1st? So just a slight distinction there.
Maybe I'll speak to this. I think there's a lot of dates and a lot of moving parts to the guidance, and I think this might be conflating a couple things. In order to reopen, if you're in the purple tier for TK through 6 schools, up until a case rate of 25, there needs to be posting and submission of the CSP to the local health officer. And then there's a 7-day waiting period. And if people don't hear, and if an LEA doesn't hear back from a local health officer, then the assumption is that, then they can reopen on day 8. The February 1st deadline is actually just for those who are already reopened. They just need to post it on their website. There is no review and there's no submission to the LHO. So I think that maybe pull those two things apart. And then there might be also layered in there a funding question as well. Brooks, do you want to try and talk about that?
Yeah, and to disagree this piece, I think as Dr. Bardock highlighted, the February 1st date really comes from the grant proposal. And so I think when folks are seizing on February 1st, that's there for that reason. As highlighted before, if you were open, you would be submitting, you'd just be posting that, and that would be submitted for eligibility for the grant. I think for risk confusing things, I will put this to one side. I think it's better to come back to this and how the grant funding piece would be proposed. But the idea is that you'd be submitting that plan by the February 1st deadline for the grant program as proposed, with more to come on that.
Great, thanks. So now we have some questions around cohorts and stable groups. We did receive a few questions related to this and really understanding. Just to start off, can you explain the difference between stable groups and cohorts?
And I can take this one, and I want to take an opportunity actually to raise up and like praise to the skies the team that is behind the so much of the work here. Janine Barbado, who really is like an expert in stable groups and cohorts. And if there are questions about cohort and guidance, I'm always like, Janine, am I getting this part right? So Janine Barbado, also Trudy Raimundo, who's on the call as well and helping answer, people are answering questions. They really are driving the technical assistance piece of it, extraordinarily helpful and extraordinarily powerful resource for people. There's also several other sort of case manager, care coordinator, case coordinator people, at least 4 or 5 people working underneath them, answering questions. And then we have subject matter experts. So there are people who are triaging the questions, and then there's subject matter experts who are answering those questions. Those subject matter experts come from Cal OSHA, from OSHPD. So we have a lot of different people helping out with all these questions. And last person, I'm sorry, Monica Morales is also helping us stand up the whole TA team. So I just want a huge shout out to everybody for doing all that work. And then I will say, I will answer this question about stable cohorts while giving a ton of props to Janine Barbado in particular, who I think of as an expert here. So stable group and cohort. Cohort is actually the general broad term that CDC uses, a lot of people use in sort of common language to talk about a stable group of students and staff, usually in a school-based setting or in a youth program setting. In California, there's a very specific meaning behind the word cohort, which is based on the fact that we have guidance about specialized population cohorts, which allows people to bring back small groups of specialized populations in small groups back onto campus for in-person instruction or for support for specialized needs. So that's the origin of the difference between the two. In the guidance, in order to differentiate between our use of the word cohort in the state of California and this broader idea of stable groups, which many people call cohorts or pods, we try to be very consistent by talking about the word stable group means that it's a stable group of students, usually associated with a staff member or multiple staff members that don't mix and allow for decreased risk of transmission and ease of contact tracing and it's sort of helping to control spread in school. And the last thing to say is, at the very early part of the pandemic, some schools shut down because they had one case somewhere because there was no stable group. Everybody was kind of mixing. You couldn't tell, had that kid cross paths with another kid, we didn't know, with staff. And so the stable group actually really helps to figure out, like, okay, we now sort of know who's been in touch with other people. And so instead of closing down a whole school, we can just do some contact tracing or know that just a small stable group of people might need to go home and quarantine.
Great. So with regard to small stable groups, how much latitude do middle and high schools have? So I know this kind of gets at the transmission rates and all the research that you've provided as background. So anything that you have to add to that?
Yeah, this is a hard one because we don't have a specific number, like it has to be this. Yeah. There's different examples across different settings. So there is some latitude because we know that the master schedule is hard and getting people into stable groups is hard. Brooks can probably actually speak much more eloquently to this about how you might structure that. And so I'll pause and let him do that. But just before I do that, I will highlight the science, which is that I think the middle school and high school story that I've shown in other slides and sort of think about a lot because I want to support that age group quite a lot, but those two age groups is two things, one of which physiologically they're a little bit more likely to transmit, and then also actually it's the school structure that really actually allows for a lot of that mixing. So those schools that we saw early on where there's a lot of outbreaks it was actually partly because I think there weren't stable groups. So I would really encourage people, as they're reopening, middle and high school, when we get to the less than 7 case rate, to really be thoughtful about those stable groups and not do huge groups of 150 or 300, which I know sometimes actually is happening for some schools.
Yeah.
So I will only just pitch in here to share what has been really the work of amazing educators and administrators across the state since last March to try to come up with solutions to this very problem. And just to lift up some of those examples, and some of these are provided in, I think it's page 19, I'll just pull it up, of the Consolidated framework, provide some of these examples. But for those of you who've been doing this, you obviously will recognize these. For those that aren't as aware, oftentimes it's worked on trying to get groups of teachers across different content areas to take on one group of students, whether that means they're all working with them as they rotate. So they're all kind of keeping them within one set group. So those students can rotate among the same group of teachers. That reduces the numbers. Some have done that where you have a single teacher who would be in the classroom physically, and the other teachers would be actually zooming in. We know we've seen definitely some schools that have taken that approach. Others have taken approaches of re-examining their entire school schedule. And obviously this is something that has already been done in many places, of moving to more of a block schedule to also further enable the use of stable groups. So those are just some of the examples that folks have used across the state as they try to tackle this, but obviously recognizing the challenges, particularly with scheduling across our largest comprehensive middle schools and high schools.
Yeah, I think Paula might have some experience with that too in her role. So if we
I can't deny that.
if we bring back 25% of our special needs students, does that fall under cohort for reporting our school status starting January 25th and then every 2 weeks thereafter?
This is a little bit complicated because it sort of depends a little bit on the circumstances. So if the school is following the cohort guidance to bring students back, then that counts as cohort guidance. And yeah, if they are just bringing back special needs students not following that cohort guidance, then it would be bringing people back for in-person instruction.
Okay. And you kind of touched on this last question. What is the limit on number of people in a stable group? Can a single adult work with multiple stable groups of students?
Yeah, and I think in the middle school and high school situation, I think that's a much more common setup, that a single adult might work with multiple groups of students. So, having stable groups of students that the only contact across those stable groups would be the one adult, and the one adult, is standing in the front of the class, lots of good physical distancing, right? All that kind of stuff. Then that's the scenario in which people, where a single adult does seem to be working across multiple groups of students. It means that your stable group is, if ideally what you do is you keep those stable groups of students pretty small. They functionally end up being a larger stable group because there's an adult who's sort of creating a link of transmission, but it's a much safer situation than if all the students are mixing around as well as the adult.
Great. So we have some questions related to the distancing, and they're all pretty similar. So I think we could probably go ahead and maybe address the first one, and then we might switch to the other topic so we can make sure we cover the questions around funding and reporting in particular. And then if we have time, we'll come back. But if you can just elaborate on just the 4 feet requirement of distancing, we had questions around distancing between chairs in the classroom. How was this decided? And then we also have the question, we do the 4 feet even if we have the plexiglass or the plexi protection between the students. So any clarification on this requirement?
Yeah, so 3 feet is is sort of the floor, that people talk about. The American Academy of Pediatrics and also the WHO both talk about 3 feet or 1 meter as sort of the floor. We looked at that number. We went a little bit higher than that to the 4 feet, partly actually in face of the new variant and just these new variants that feels like we should probably build in a little bit more of a buffer. The other part of it is that the physical distancing also is going to determine the density of people in the classroom. And that gets to this issue around the plexiglass question, which is that we know, you know, in the beginning of the pandemic, we sort of felt like plexiglass was going to be a reasonable first, you know, a reasonable additional layer, which it still is, but we actually have much better data that the way COVID-19 transmits is partly through these sort of aerosols that float a little bit. They don't just hit against a plastic barrier and stop. They can kind of float around through the room, and that's why there's a greater emphasis on ventilation in the last probably 2 months, I would say. So that's why we've gone to that 4 feet to be a little bit clearer and to actually decrease the density of people in the classroom in addition.
Great. So we're going to shift to funding. And Brooks, I think you might be able to help us with these questions. So the first one, we are a K-12 school district. Will ADA be funded for our entire district or just those schools that reopen?
Great. And before I start, I want to quickly, I've seen a couple of comments here in the chat around a comment I'd made around the grant program tied to February 1st. So I do want to clarify for folks that if February 1st comes up in the grant proposal, it also is applicable for those that have already reopened for in-person instruction. You would have to both complete and submit, well, and post, complete and post your COVID-19 safety plan to your website by February 1st. So I just want to clarify that point. If you are a K-12 district, will ADA be funded for your entire district or just those that reopen? It will be funded for your entire district. So if you are bringing back, and this is again all in the context of a funding proposal that has that is not yet enacted. So I just again to highlight that piece. But as proposed, you would qualify based on bringing back your TK to 2 students and then ultimately elementary grade students by the defined timelines, and then serving those identified groups of students across all grades. If you do that, your grants would be generated based on your entire student body.
Great. Is leadership considering alternate methods of apportionment that would allow schools to maintain a remote attendance option for synchronous, asynchronous learning?
So I think it's important to hear that in the proposal, in the grant proposal, the requirement is simply that you are offering in-person instruction to students in those designated grades or in those designated student groups. It is not that all students would be required to attend. And so, in fact, it's explicitly contemplated and listed in the guidance that you would be continuing to offer a distance learning option for those who choose that.
Does the plan funding cover all students in grades 7 through 12? If not, which students, if any, do qualify as schools serving grades 7 through 12?
So I'm just trying to digest that question a little bit.
I know.
I think we covered this a little bit in response to the first question.
Mm-hmm.
When we talked about the students who would be required to offer in-person instruction to as a condition of receiving the funds, that covers our students with disabilities, foster youth, homeless youth, as well as students who are don't have connectivity to participate in distance learning. All of those students across all grades would be need to offer in-person instruction. But the funds generated, again, would cover all grades.
What is the timing of the funding distribution?
So as proposed, the State Department of Education would be required to notify all school districts of their grant award within 20 business days of the submission of the application to your County Office of Education that then goes to the Department of Ed. Funding would then flow. This is based on typical Department of Ed and State Controller Office timelines. Generally, it would be a few weeks later after that point.
Okay. If a district signs up for the grant funding and decides that they do not have the capacity to complete all of the requirements, can they decline the money at a later date?
So in the way this would work, again, as crafted, if a district went down this route and it didn't meet the requirements and weren't able to do that, the funds would be returned to the state using the state audit finding process.
Okay. So this section relates to the reporting, and this is actually something that CCEE is even involved with. So Dr. Bardock and Brooks, Mr. Allen, if you want to add anything as we kind of go through these questions, but we know we do have a reporting deadline coming up. So beginning January 25th, every local educational agency, and this is part of the question, and we can clarify how we're defining an LEA if we want to. School district, county office of education, and charter school and private school in California shall notify the California Department of Public Health whether it is serving students in person. Information shall be reported via a web form that will be made available by the California Department of Public Health. Where is the form located? Can it be linked under the transparency section of Safe Schools for All? And that's where the directive is actually posted in that transparency section. Also noted in, I think, Appendix 4 for the school reopening, the consolidated guidance document. So if you want to maybe clarify what are the plans in terms of posting the form to populate and some of the processes related to that.
So
I'll say something because I emailed Deb a little bit, Deb Brown also, who's, I believe actually she's also on the call.
Yes.
So maybe Deb, do you want to answer this one? Because I think you're in a good spot to do that.
Yes, sorry, I needed to get off mute for a second. Yes, so it will be available by a web form as it's noted. Right now, where it will be housed, still need to make some determinations because one of the key things or one of the key differences with this form versus the other request forms is that these are only to be for LEAs to submit the information. So we don't want others to be able to open the form and submit information. So what we'll be rolling out over the next couple of days is a process by which LEAs will register or authenticate a user to be able to enter the information, and then that data collection. So that's the first step, will be to authenticate users. And then the second step will be to start submitting the information on this coming Monday, the 25th.
And actually, I think Tom Armelino with CCEE, he's also part of this expanded panel that has access to unmute. And Tom, I'm going to ask this question if you want to maybe elaborate. Is the in-person status reporting going through the county offices of education or through a direct interface with the state? And so I know there's some coordination even with CCESA. So if you want to maybe unmute and elaborate on that as well.
Yes, so the school districts and charter schools and the private schools will be notified in the next couple of days directly from their county office. So folks should be looking for an email specifically to the leadership in that district that will specifically share with folks, as Deb just mentioned, where they'll need to go. They'll have to identify an individual who will then register. And that individual will then be able to submit the data based on the link that will be provided in some of this communication. So encourage folks to kind of look through that from their county office. And if folks don't hear directly from their county office, we just would suggest that they contact their county office to make sure that they have access.
Great. And of course, it's always great to end with something that's coming up very quickly. And so I know the counties are working on this and they're getting ramped up for next Monday to start that process. So we do have some questions related to vaccinations. We have a couple of minutes left, Dr. Bardock. So I know there's quite a bit of new information, evolving information related to vaccines. And so is there just anything in particular that you want to share related to vaccines? We just wanted to acknowledge that we've received questions and this is definitely a topic that we'll be coming back and revisiting in future webinars.
Yeah, I think that the sort of summary situation right now with the vaccines is that there are a lot of moving pieces right now. The overarching philosophy is still that education is extremely important. So as we think about the vaccination sort of strategy, there's a couple of things. One is that right now there's actually a supply issue. So the news is that we're actually waiting for more supply is part of the problem. So as people are sort of wondering, when are we going to get more, or when are educators going to get vaccinated? Part of the reason why we can't say, oh, for sure, here's when it's going to happen, here's how it's going to happen, is actually part of the supply issue. So as this new administration at the federal level comes in, hopefully there'll be a little bit more clarity on that. And then but there is an overarching sort of commitment to the idea that, COVID-19 has, terrible effects, direct health effects, and the focus is on protecting people in the highest age group and the most at risk medically, but also it has very serious indirect effects, which are mediated through school closures. And so there's a real emphasis on the importance of schools should be the last to close and the first to open, and also the vaccination, priority also reflects that idea that, educators are extremely important, and so there's a focus on that population as well.
Great, thank you. Well, we are at the end of our time. We just wanted to remind people of the hub, the Safe Schools for All hub, which is a lot of information, a lot of guidance, but also the opportunity to request assistance and get additional support. This is a table that you'll see if you click on the school administrators section and you submit the form. You may not even have to need to submit the form if you want to see all of the guidance in one place. And so we just wanted to remind people of this opportunity. As always, thank you to the panel. It's been very helpful, insightful, and we really appreciate your time. Thank you to all of the participants that were able to log in and join us today. We will be posting the slides and the recorded webinar, and we will continue to collect questions. We received quite a few in the Q&A, which we can respond to, and we'll be looking forward to future webinars and future FAQs to share and disseminate. So thanks again, and hope you have a great evening.